So glad you're here. My name's Dave Fuller. I'm the Associate Dean for Research here in Public Health and Health Professions. I'm thrilled and excited to welcome you to PHHP Days. This is a celebration of who we are as a college. A pillar is the structure that supports a building and is the foundational for its existence. And so what we're going to do today over the next hour is hear about some of the pillars supporting our college. Our missions include teaching, service, research, clinical work. And we're going to hear from 4 of our faculty who are going to tell us about what they're doing in those areas. And they're going to be short presentations with big ideas. So short talks, big ideas. Our first talk, I'm really honored to introduce Dr. Mark Bishop, who's going to tell us an origin story. So the Physical Therapy Equal Access Clinic, the origin story. So Dr. Bishop, welcome.
Yes, thanks, Dave. Welcome, everybody. Welcome to PHHP Days. My name is Mark Bishop, and I was asked to share with you a part of my experience in the college related to service. And so I'm going to be talking about the origin story of our PT Equal Access Clinic. So to start, we're going to do a think, pair, share. The think, pair, share is where I'm going to tell you a story and you're going to think about it a little bit and then we'll discuss with each other. And our story is this. You have a friend who's riding a scooter in the rain. They get cornered too quickly, crash, hurt their shoulder and their knee. After they've left the emergency room, they've been told they need to seek some rehabilitation services. Here's the problem. They don't have any insurance. So what we're going to do is now think about where that person could get their rehabilitation and how they could get it. This is usually a quiet time unless you're a PT student where you're talking while you're thinking. 10 more seconds. So now we share. So how about someone over in this side of the room? Where would you go to get rehabilitation services if you had no insurance? YouTube, all right, there's a solution. Let's go for quality supervised care from an expert. Someone over here, where might you go? Your house. My place, all right, very close. Thank you, Dr. Judge. What you might want to do is go find somewhere that offers pro bono care. And each of our professions in this college has a code of ethics that explicitly states that we provide pro bono care, or at least has a position related to pro bono care. Egocentrically, as a PT, my code of ethics says I must provide pro bono care, or at least support an organisation that does so. Another example is the clinical and health psychologists who have an explicit statement about providing care that's pro bono. So before we go much farther, let me be clear that this is not a new idea in our college. We have a very long history of this, and this is not the future of our college. This is just an example of something in which I was involved. And in fact, starting in the 60s, our college has been involved with the Department of Health and in the community providing pro bono care. And in the 80s, faculty and students went to Acorn Clinic in La Crosse. Who knows where La Crosse is? Yes, get on 34th Street, keep going. Just keep going. At the same time, or very parallel, the College of Medicine started their first pro bono service in the 6th Street Clinic, and in the early 90s, students became part of that. Then the dental students, and eventually clinical and health psychology students were offering care in the Equal Access Network, but there was no rehabilitation. And so, 2008, Class of 2009 came to me, and this is Lucas Van Etten, who's now the Dean at MSU, and Lucas said, I think we should have a clinic. I think we should be in medical EAC. I know a guy. And so Lucas and I met with Dave Feller and a couple other people from EAC, and it just couldn't get the momentum going. There were a couple of hurdles and barriers. And so Lucas went on clinical experiences, and it fell to the next group of students. And this is Brian Frost and his cohort. And Brian said, wait, the director's in my PFF group. So the director of the Med EAC was right there in a small interdisciplinary class with Brian. And he said, instead of being in the clinic, maybe we could be near the clinic. I know the place. And so he found a place, Gainesville Community Ministry. And I put this up, this is on the corner of 3rd Street and 4th Ave. I put this up specifically because it was a classroom. They had GED classes during the day. So the students went in and turned it into a clinic. I mean, look at this. These guys, they've got shower curtains to make dividers, they got massage tables, and they set up a clinic. And over the first year, there was about 10 PTs that volunteered, 90 students went, and we had lots of patients show up. These guys put together an extensive manual of procedures, which I claim to have read, but it was just so thick. That manual of procedures went on to become a model for our other community groups at that time. And then we had an outstanding number of community volunteers who participated in the clinic, including someone who is now on our faculty and serves as the faculty mentor for EAC. So a nice circle of life there. 2015, we moved into a bigger space, able to offer some other services, including for people who needed neurological rehabilitation. Management changed. It's under the directorship of Kim Dunleavy now and continues to grow in complexity and service options for our community. So, why am I telling you this boring story? Well, turns out that one of the things I learned in this experience is that the students in our college are imaginative and capable, and as soon as I stepped out of the way, they solved all the problems and magic happened. The students set up this clinic. Students run this clinic. Outstanding. The other message I have is that now, perhaps more than ever, pro bono services are something for us to consider. Certainly in my profession, reimbursement keeps decreasing, coverage keeps changing, we're seeing other sort of problems related to access in care. Resources are being modified across the spectrum of healthcare, and so perhaps pro bono care is more important now than it ever has been before. That is my talk.
We do have the opportunity to ask a question or two if
question.
anyone should have them. There's an incredibly intense light, so I have trouble seeing.
We do. We do.
Any questions or comments for Dr. Bishop? I think it was just so spectacular that there are no.
So spectacular, Dave.
Question.
I just have a question. How these pro bono services are advertised through our communities? How can we reach these resources throughout the community?
All right, great question. The question was about where do you find the resources? There's a couple of different options. Very specifically for the equal access resources, you can literally just Google Equal Access Clinic Gainesville, and you'll see all the different services related to equal access. There's some other services in town run through church organizations and volunteer organizations, like the Gainesville Community Ministry has a small medical clinic. Acorn Clinic closed out in La Crosse, but a lot of those people still go around in the mobile health clinic that goes across Gainesville. It was on 13th Street at the church near my house recently. So there's lots of those type of options. These lights are really intense.
What is the general demographic of the clinics?
I can only tell you about what the demographic was when I was there in 2008 through 2015, and it was mostly uninsured people who lived, who were coming to care at the 6th Street Clinic in Gainesville. If Kim is here, she might be able to. Oh.
Thank you. The 50% Spanish, 50% English speaking, underinsured, uninsured, and that includes students, because unfortunately students don't have a very good insurance. So it's anybody whose copays are exorbitant. And it varies across the board in terms of ages. We have a number of people that have neurological conditions, but we also have mostly musculoskeletal conditions coming to our particular clinic. Occupational therapy, I think, has a different demographic, and I'm sure they can talk to it. Psychology has a different demographic as well. We do some telehealth now for people that are not directly in this area but don't have services either.
Thank you very much, Dr. Bishop, for kicking us off with that origin story. I want to give a special acknowledgement to Dr. Dunleavy, who has picked up the clinic and kept it going. So thank you for all the work you're doing in that space. And I'm pleased to introduce our second speaker, Dr. Catalina Lopez-Quintero. And we're going to hear about informing drug use prevention through population neuroscience, the brain in context. So we're looking forward to that. The floor is yours.
Thank you. It is an honor to be presenting the pillars of this college. And today we're going to be talking about the brain in context. 6 out of 10 adults in the US have a chronic disease. 4 have at least 2 chronic diseases. And at the College of Public Health, we are committed to decrease or reduce the burden of chronic diseases in our communities. And how we do it? We are trying to address most of the preventable risk factors for chronic diseases. So we have seminar work that is conducted in trying to improve physical activity and functionality. We have also seminar research conducted to improve diet and the impact of obesity and metabolic diseases. And we also, in my case, we are doing research that reduces the impact of tobacco, alcohol, and substance use. All this research is based on addressing prevention from first level to third level. So today we're going to be talking about substance use prevention. And in my case, I'm going to describe prevention that addresses the onset of substance use and also to the onset of these use disorders and the consequences of that, like developing psychiatric comorbidity. Over the years, we have been able to learn actually how is our brain on drugs. And we have been able to identify all the neurocognitive processes and all the neurotransmitter systems that influence addiction. We have established how all the structures that participate in the process of developing addiction and identify specific structures. We have been able also to move from let's say, the diagnostic approach in which we look at disorders to a more dynamic process in which we identify specific areas of the brain that are involved in neurobiological process that indicate symptoms and that are key for developing the preventions that we're doing today. I'm going to be talking about some developments over the last years that are changing prevention and how we look at prevention, because it's not only understanding how the brain functions or which structures are present, but also understanding that the brain in a context and in a more broader aspects of that. So I'm going to be talking today about population neuroscience, which is the integration of neuroscience with epidemiology, genetics, data science, and some other disciplines, social behavioral sciences, in order to understand how our brains function in context. And when I say this is important because there is no way that we can understand how our brains develop and how we will function if we don't understand in which context that happens. So when I talk about context, I'm not only talking about the personal networks that we have. I'm talking about our communities. I'm talking about countries, regions with the policies and economic aspects that it has, and also even our history, because that marks also generational processes that are important for our brains. So that's one of the first lessons that I would like to emphasize. It is important to study the brain in context. And some examples of our new research has shown, actually this is quite of an established findings, that it shows that the volume of total gray matter changes as a function of where you live, the socioeconomic status that where you live. And this is important because the total volume of gray matter has been associated with the emergence of different psychopathology and disorders, including substance use behavior. So it's important to look at context. The second lesson that we learned is that it is necessary to look this over time, even looking generations back. And through this research, we have been able to learn things like, for example, exposure to substance use at prenatal stages can influence the development of psychopathology. In this case, we observe how some problems like externalizing and attention problems emerge when kids have been exposed to different degrees of substance use during pregnancy in the prenatal environment. And these processes also evolve over time, and we have been able to understand the mechanisms of how it happens. In this case, for example, in recent research, we have established that close relations between the infant and the mom might influence later problems with communication and also socialization practices. When the mother is more sensitive to the needs of the kids in a timely manner, then that kid will be able to better communicate with the mother later in adolescence, and also will be able to socialize better and understand other people's needs. Also, we have been able to understand the importance of critical periods. So in the process of studying the brain, we have established when the brain develops. So we have established that more or less we finish to develop at the second decade of life. But if we are exposed to certain specific exposures at a particular time, and that might be detrimental for our health. For example, through my research, I've been able to establish that when kids start to use drugs very early, they have an increased risk of developing addiction and other conditions. And that is important because then our focus on prevention should be to try to delay the age at which people start using drugs. Unfortunately, some of these risks accumulate over time. So risk in terms of environmental exposure or social exposures, and that increase also our propensity to develop disorders and other psychopathologies. And that's the case that we have seen, for example, with some dementia or other diseases in which all these risk factors accumulate with the risk of developing dementia. But not everything is bad news, because we have been observing that when you remove one of those risk factors, the risk of developing those disorders also decrease. If you can see here in the pink line which actually indicates the probability of developing dementia for former smokers approach the probability of never smokers. And this brings us to an important third lesson that we have to take into account in relation to prevention, which is that our brains are resilient. We have the capacity to adapt to different circumstances, environmental threats, and also to adversity in a way that we are still learning from that. And that capacity actually can help us to overcome adversity and live a healthy life. Some of the research in this area has shown that if we, for example, develop meaningful relationships and we have a connection with our communities, if we have positive thoughts, if we remove some of these risky behaviors and actually adapt healthier behaviors. And most importantly, and I think I'm preaching to the core here, find purpose in our lives, that might reduce also the risk of developing dementia later on or other conditions. But our task is not over. I mean, we know this thing and we have to put it into practice. So one of the things is that we have to continue to develop prevention, but ideally a prevention that is personalized prevention, where we understand the specific characteristics and circumstances that affect individuals and in their lives. And how do we do that? Personally, we're implementing our research, and I see it in the college that we are using more technologies to understand actually how the brain develops and how it functions in particular life environment, in the natural environments. Also, we are learning to use new methods, new technologies, and new statistical and data approaches to understand that. And we're gonna keep doing that because I believe that there is nothing more important, and something that I have learned in this college, that it is important to work together and collaborate with the different disciplines because, as I mentioned at the beginning, our commitment is to reduce chronic diseases in our populations, and I feel that we are in the right place to do that. Thank you.
We have time for a question or two, if anyone has one. All right, well, thank you, Dr. Lopez-Quintero. That was wonderful.
Good time for
Oh,
one
we do
question?
have a question.
Yeah.
Sorry, you have to come back. Maybe too late.
Ah, I have a question.
Yeah.
Yes,
Oh,
sorry. I wanted to ask, you covered a lot. So do you envisage for someone like me, maybe when I hit later ages, say when I'm 60 and I come to you and say, I want to avoid having dementia. When you talk about prevention science and personalized medicine, do you envisage from what you're saying, you'll be able to look at my history and be able to give me specific things that are personal to me, different from her, for example? Is that how you anticipate this will work? Can you comment on that?
yeah. So in personalized medicine, what we want to do is try to develop interventions that specifically address the individual risk factors and also the environment in which that person develops. So yes, of course, you both might have different, I don't know, you do different physical activity or engage in different behaviors, and that will have to be taken into account. Also, we have different histories, genetic factors that might make us predisposed to certain diseases. So the idea is to gather that information and being able to decide, oh, this works better for this person, and because given these risk factors. Yeah.
Again. So our third pillar presentation this morning is from our chair of speech, language, and hearing sciences, Dr. Charles Ellis, and he's going, I think I just got clapped off the stage, so that's
Thanks, Dr. Fuller, and thank each of you for being here. It's a great opportunity for our college to showcase all the great things that we're doing here. These are our pillars. I would say that primarily I see myself as a clinician who has had an opportunity to learn a little bit about research and learn and to teach a little bit and influence. But ultimately, I see most things through a clinical lens. But I want to talk about kind of the intersection of my clinical background and how it intersects with research in terms of the things that I'm interested in, that I like to study. I found this quote that I think is very important. I'm not here to give you a history lesson, but history is very, very important, and that history of individual people in the society that they live in, they're also constantly intersecting to drive the types of health-related outcomes that we're all interested here in studying. And that's probably why post-World War in the 1950s, there was originally just a thought of building a medical school in North Florida, but some other folks had some other ideas that we need to really house everybody kind of in one place and to bring on these new disciplines of physical therapy and occupational therapy and medical technology online so that we can have a more interdisciplinary approach to care. So in 1958, the college was founded, and it expanded over time and eventually brought public health online in the 1990s. Just to our north, something also very interesting was happening kind of in the public health realm that I think aligns with what was happening here in North Florida, that there was a little known physician who was kind of a pioneer of sorts in this little town of Claxton, Georgia. Claxton is mostly known for being the fruitcake capital of the world. And many of you have had this fruitcake. I kind of hate it. It was always around, it was always a gift. But that's kind of what this little town is known for. Dr. Haynes, he was a pioneer because he was one of the few white physicians in the Deep South who treated both Black patients and white patients. And one of his observations, because he got to see all of these patients, is that white patients had far more cardiovascular disease than Black patients, something that is really hard for us to think about today, but that was what's happening at that time. And it also brings us back to that linear health and disease doesn't move in a linear fashion, that it morphs and it changes and it affects different population groups at the same time. So at the same year that this college was founded, Dr. Haynes went to the NIH and they gave him a small grant to study. And what he found was his observations were correct, that even though Black people were far less educated, they all lived in poverty, they smoked more, they had higher blood pressure, but they had far fewer cardiovascular disease than the whites in this part of Southeast Georgia. And so that's kind of one of those things that's it's hard to imagine that. And I've heard a lot of folks use this study and explain it to align with what's happening today, and that's actually not accurate. And so this Evans County Heart Study, which began in 1958, was the seminal study of cardiovascular disease in the US, and it moved on to the Charleston Heart Study and the Jackson Heart Study, and then it moved up north to Cincinnati. It's just a reminder that longevity is only promised to a few, and that when we are trying to understand health and disease, that there are real people that are being impacted by health and disease in very different ways. This is an example of a family. And this is a picture from 1970, and then when you look at their family tree less than 30 years later, there's only one grandparent alive. Both parents are deceased, all great parents are deceased, and 3 or 4 grandparents. And this is a family who would have been part of the Evans County Heart Study, but didn't reap the benefits. So the things that we do now, they don't translate in real time. We learn things, and health and disease is moving at the same time that we're trying to understand how to achieve the best outcomes. If there's one thing that I've learned, is that this is the science that we're trying to understand. It's super hard because it's trying to understand the beliefs and attitudes of people that vary greatly in a society that's constantly changing. And as a result, the outcomes are very different across people and different parts of society because these intersections don't always align. One of the ways that we're looking at it in our department and really throughout the colleges, so what does this really mean for organized rehab care? It's kind of the same issue, that this is probably our perception of organized rehab care, that if we go over to UF Health, that everything is at our disposal. Any specialty is available, and it's just a matter of getting into the system, when in reality, that's not really how care works. This is probably the reality for most people in society, and this is what we're trying to understand, that there are these different pathways that patients can take. And even though you have a world-class system, and UF is one of many, all of these doors are not open to everyone. And it's not simply presence or absence of insurance. And I think that's one of the areas that, in general, when we're trying to understand health-related outcomes, it's not always about insurance, that there are decisions that are made by individual people, there are decisions that are made by providers, and then there are structures in place and systems, and no one is necessarily to blame. We're always looking for someone to blame, and it's not that simple. That patients have beliefs and attitudes about health and disease and rehab, and they make their own decisions. Sometimes those decisions are to choose not to access something. That I'm not going to access UF healthcare because of some historical issue that their family has had for multiple generations. As providers, we also have biases and things that we're trying to factor in directing people down the same pathway. And then even in systems that have everything in place, accessibility can be a very big problem. So even though UF Health is right here in North Florida, it's 15 minutes from Newberry, Williston, these little towns, Waldo. If you were to go and talk to some of those people in those cities, they would probably tell you that they don't necessarily have access to a world-class health system for many different reasons. It can be simply their copay, or it could be the fear of the $20 parking, or it could just be that I can't really take off work to go into Gainesville to access what is believed to be awesome care. And I believe that, but I also understand that. Oh, sorry. I also believe that access is a very tricky thing, and people are complex, systems are complex, and so outcomes become quite variable. So ultimately, we have 8 world-class departments. I believe that there are a lot of very important questions that we're trying to answer in a time of socio-political turmoil, or whatever you're going to call it. But it's also, I believe, an opportunity for us, because these bigger questions can only be answered through integration. That individual departments, we're going to continue to do world-class research. We're going to continue forward whether NIH cuts their budget or not, because scientists are always going to have questions, and they're always going to seek to answer those questions regardless of what is going on around them. But the more important thing is it's going to be difficult. But I believe the pendulum it's always swinging, and it rocks like a boat. And sometimes some people get kicked off. I do believe the strong will survive. I think that we're in this time of some people will lay down, others will stand up, and we will move forward. PHHP, I think, is well positioned to move forward, to understand these different pathways and differential outcomes, because we're in essence our own little R1 university. When you look at our research budget, it meets the metric of what an R1 university is. So we're well positioned to answer these questions. We do have to keep kind of our eye on history and understand that it's moving in different directions. And then we'll figure out a way to answer those questions of why these different pathways exist and how they impact outcomes. Thank you.
Any quick question for Dr. Ellis?
All right, I said it all.
Thank you so much, Charles.
Yeah.
So as we get ready for our 4th and final pillar presentation, I want to remind you there is lunch available. So on your way out, there's going to be some sandwiches available in, I think it's 301. So please grab a few and join us for lunch. I want to thank you all for taking the time out of your day to be here. And now Dr. Steven Foti is going to tell us none of this is possible without the foundation of biostatistics, right? That's a fundamental pillar for how we understand data and science. So thank you.
All right. Hi, everyone. I'm so thankful that you are all here with us today. I want to start out with some quick audience engagement. How many of you have ever taken a biostatistics course? Plenty of hands, perfect. And keep your hand up if you feel like you fully understood every single thing from that biostatistics course. Let the record show that no hands remain up at all. Okay, noted. So today, what I want to attempt to do is both highlight the importance of biostatistics in public health, but I also hope to broaden your perspective and maybe give you a different lens with which to look at how you engage with biostatistics. So the next time that you're in a course or reading research or conducting research, hopefully that experience will be as beneficial and fruitful to you as possible. So I want to start out with a concrete example. I want you to think back. I know that we've all experienced this because we all lived through it. I want you to think back to mid-2020. The world was dealing with a novel pandemic, right? This disease was spreading faster than we felt like we could understand it. We needed answers to these questions. How deadly is this disease? How does it spread? How do we protect people from this virus, right? And so it wasn't just epidemiologists and doctors and health professionals, policymakers working behind the scenes to answer these questions, but also biostatisticians. They were involved with helping to figure out how do we collect appropriate data to help answer these questions. How do we use this data to predict the trajectory of this virus? And how do we use this information to help us inform decisions that we need to make for the public, right? So, I think that biostatistics really acts as sort of a way to, it serves as a bridge between raw data and decision making, right? So when we have these high stakes questions, we have these high stakes questions, how do we go about answering them? We have to figure out appropriate data to collect and use that data to make decisions. So, and that's really what I want to get at today. And so, I think an important step in all of the biostatistical process is this idea of statistical literacy. Statistical literacy is a topic that I like, I study, and I try to teach throughout my courses as well. So first of all, what is statistical literacy, right? So a simple definition for statistical literacy is simply the ability to understand and critically evaluate data in your daily life, right? So obviously, just some basic examples for public health professionals. This is important to be able to make decisions on allocating resources. It's important for patients and anyone out there, right? Individuals for making informed treatment decisions. And why does statistical literacy matter for public health? Further, well, of course, it helps everyone to understand research findings. It helps everyone be able to spot misleading claims in research or in the news media. And it helps everyone to make informed health decisions. Again, as just a quick concrete example, the idea of vaccine efficacy, right? This is a phrase that we hear often, efficacy of a vaccine, but what does it really mean, right? So, for example, what does it mean for a vaccine to be 95% effective, say, right? So it doesn't necessarily mean that 95% of all people who receive the vaccine are, in a bubble now, are completely protected from a disease or a virus or something. But what it does mean is that, it's speaking more to the results of the clinical trial that was conducted for that vaccine, right? In the clinical trial, you have folks who receive the treatment, the vaccine. You have people in the clinical trial that receive the placebo, and 95% vaccine efficacy would imply that most of the people in the treatment group had a lower risk of having the disease than in the placebo group. And it does, of course, depend on what the clinical outcome is that the trial is actually assessing. So I think statistical literacy is important. I think it empowers individuals to understand data, work with data, make decisions with data. But the field of biostatistics is obviously a lot larger than just statistical literacy. And so I think the field of biostatistics really helps to empower not just individuals, but entire systems, right? So the whole idea of the gold standard, randomized controlled clinical trial, right? The reason that we're able to establish cause and effect relationships between treatments and outcomes, it all lies on the foundation of statistics and biostatistics. So what I want to do is highlight a couple of the major aspects of the work that biostatisticians do, and of course, highlight some of the work that folks in our department do as well. So the first thing is collaborative work, right? The first major aspect of what biostatisticians do is collaborative work. So we're working with epidemiologists, with policymakers, doctors, clinicians, right, to help them carry out their research, right? You have a research question, you work with a biostatistician to help facilitate your data collection and interpretation. So I wanted to highlight here Dr. John Kerala. He's from our department. He is the Associate Director of the Children's Oncology Statistics and Data Center here at the University of Florida. And recently, Dr. Kerala was the senior statistician on a clinical trial where doctors were looking at a new treatment for childhood leukemia. And as the statistician, helping to facilitate the design of the study, thinking about the collection of data, the recruitment of patients, as the data progresses through the entire study, to ensure that the conclusions that we draw from this study are sound, right? And as a result of that work, they actually just recently discovered this new treatment approach for this particular type of childhood leukemia that I won't pretend to be an expert in. But they said that this trial's findings represent the biggest breakthrough in childhood cancer treatment in decades, right? So that's fantastic work. The second major aspect of what biostatisticians do, of course, are coming up with innovative methodology, right? So developing new tools to address and solve emerging challenges. This here, Din Ma, is one of our doctoral students, and he worked with his advisor, Dr. Li Chen, and some other graduate students and faculty neuroscientists here at UF to create an AI-driven framework to map the brain metabolome in 3 dimensions from a series of 2D images. So, this work here, right, it's about dealing with new types of data, harnessing AI to help us analyze data in new ways, right? And so we want to develop these new methods in ways that we can still be confident that we're coming up with appropriate conclusions from a set of data or new complexity in data. For disease prevention and treatment, they've opened a new angle for biologists to study. So all this to say that biostatisticians often are the ones working behind the scenes, but their influence is still profound, right? Of course, it's often the researchers or the scientists coming up with the questions to ask, and biostatisticians are there to help you formulate those questions and use data to answer those questions. We help ensure that data-driven decisions are reliable, reproducible, and they're relevant. So as we look forward to the future, I think there's more and more public health challenges that are growing. They're becoming more complex. We have big data, right? There's more data, and there's more accessible data than ever before. We're trying to harness the power of artificial intelligence to help analyze that data. There's precision medicine, where we have more and more complex data. How can we use genetic and environmental and clinical data to make decisions on individual treatments? And of course, because there's so much data and so much access to data, there's also the potential for misinformation. So that's, again, where statistical literacy helps to avoid that. In conclusion here, every major health decision that we make relies in some way on biostatistics, right? Whether we're developing treatments, allocating resources, or creating new policies, it involves biostatistics in some way. To everyone here, I hope that by engaging in statistics education, statistical literacy, and research, it ensures that we are able to continue moving public health forward. And to come full circle here to our opening example, right? Our response to the COVID pandemic wasn't just about collecting data, right? It was about understanding data. It was about communicating with data. It was about interpreting that data to be able to act on that data. And so, the next time you're engaging with biostatistics, the next time you're in a biostatistics course, don't focus on the math or the calculations. Really think about why we're doing it. I think understanding the concepts, understanding why we're doing what we're doing, may even help you understand the calculations or the math behind that. What I want you to take away is that together, through understanding and communication and collaboration, we can turn data into better health for everyone. Thank you.
Is anyone else like really fired up about biostats now? Like, woo! Questions for Dr. Foti? Yeah, one. Can you just shout it out, maybe, or wait for the mic?
You talked about statistical literacy and just misinformation, and we kind of are in this little bubble of just people who are interested in public health. But how is that something that you generalize into the population of people who might not have any idea what biostatistics even is?
Right, that's a great question. And one that I maybe don't have the answer for. No, this is a great question. It's something I think about a lot, right? And I think something that I would like to do more of is have more community engagement. In the past, I've done things like, in the K-12 setting. My background is in statistics education, actually, and a lot of that field operates in the K-12 setting. So it's about getting statistics into classrooms earlier. There's research that shows that, children as young as 3 and 4 years old have the capability to understand statistical thinking, at a lower level, even if they're not, mathematically there yet. But, so I think by talking about statistics sooner, talking about data sooner, understanding the concept of variability, and also by trying to engage the community as much as possible, just kind of have to spread the literacy.
There's a lot of misinformation in today's health environment. As a biostatistician, you have ideas about using biostatistical messages to combat misinformation more effectively than we've been able to do so far?
Yeah, I mean, again, it's tough to try to, it's like we're trying to change the minds and the way that everyone thinks, right? To be more aware of the nuances of data and data interpretations. Honestly, one thing that I kind of encourage my students to do in class, but I think that large language models and ChatGPT, they're not perfect tools. They don't always give you the truth or the correct answer, but it can be really helpful to chat with. Okay, that was an unintended pun. Really helpful to really have informal conversations with, though, about statistics. So if you're in a statistics class and you're learning about a method and you're like, why am I doing this? Or if you don't understand something about it, I think using AI and large language model tools to be able to ask a question that helps you understand it is often a very helpful approach. So maybe that only gets at a small piece of that question, but I think it's one thing that we can all at least do and try to improve our understanding of these concepts.
Well, my question kind of follows the same. Can we make a statistical training fun? And how? Like a fun experience.
Make statistics
Yes.
fun.
I mean, it is fun, right?
I think you said it. That's a mic drop, so just drop it.
I think we can make it fun by helping people connect statistics with their research questions, right? So everyone should engage in statistics in some way, so that we can. How can I do a better job of making you care about the statistics based on the research questions that you're trying to answer, right? So I meet you where you are instead of trying to bring you in the model, sort of thing. So maybe that.
there.
Thanks again. Let's do a 1-minute recap. So we heard about a clinic that was founded and it's provided our students with incredible opportunities, and it is affecting our community, providing rehabilitation services. Amazing stuff. We heard about how a patient's individual experiences affect how their brain develops and how they process information. In the same vein, we heard about how a person's individual attitudes towards healthcare is such a complex thing to understand and tackle, but we need to do that in order to provide the best healthcare and move forward as a field. And then we just heard that biostatistics is fun. So with that, this is our inaugural Pillars session. So I hope you enjoyed it. I hope this becomes a tradition in the college. Please be here tomorrow, same time, same place. We've got 4 more amazing talks. And maybe let's thank the speakers one more time.